Great. So I'm going to give mainly an overview on the testing for Lyme disease, just to help you guys with the interpretation and the classification of the diagnosis, which is the main thing you really have to worry about. But in the slides, I have several dozen more slides following what I'm going to present today, and I will email them out so you can have it to review. It'll go over a lot more just about prevention of Lyme disease, kind of the presence of Lyme and the ticks in Michigan, diagnosis of Lyme and treatment of Lyme, just so you have that information. But it was really long, and we'd not get through it today in the time allotted. So go ahead and get started. This is a really busy slide. The next few slides are really busy. But this is from the CDC website, the National Notifiable Disease Surveillance System. Just a reminder, these definitions are used only by us in public health to define a case to be counted. It is not intended to be used by healthcare providers or for us to tell healthcare providers how to diagnose and treat Lyme. It's only to be used for us to define a case in order to help us know how to count it as a case. It does pretty roughly follow, how a clinician should diagnose Lyme, but again, it's not to change how they are diagnosing it. It's only for us for how to count it. So the first thing is the clinical criteria. An illness is characterized by symptoms as reported by a healthcare provider to us. So whether we're talking to the healthcare provider or we're reading it in their records, it's not based on patient reports. We need to get reports from the healthcare provider. So one would be the erythema migrans rash. And there are some pictures in the slide deck. I'm not going to go through them, but they are in the slide deck about what that rash is. And it must be at least 5 centimeters in diameter to meet this definition per the CDC. Lyme arthritis is another definition. It's a late manifestation, but it's the second most common manifestation of Lyme. And so that's objective joint swelling in one or more joints. There's nervous system manifestations, which are listed here. It's either meningitis, cranial nerve involvement, particularly facial palsy, radiculoneuropathy, or encephalomyelitis. And then there can be cardiovascular involvement, which are heart blocks, and sometimes you can have myocarditis. But again, these would be the definitions that you would use based on healthcare provider reports for the clinical criteria. For the lab criteria, again, I know this is busy. These first 3 I put in a smaller font on purpose. These are talking about actual direct testing, so isolation of the organism, Burgdorferi, or Bordetella burgdorferi, or Bordetella mayoni, which is another organism that causes Lyme, mostly from Europe, but it's really rare to see that in the U.S. Detection of the organism itself through like PCR testing or staining. So these first 3 tests can be used for diagnosis, but almost never are you going to see these kinds of test results. It's really hard to isolate the organism. Maybe if someone has like fluid taken off their knee or something, you might see it. But mainly you're going to see this number 4, which is serologic testing. And these are the things we'll talk about much more in the coming slides. And these are the standard tests that should be used for actual diagnosis by a clinician. Would be the 2-tier test, which is either the standard 2-tier test, which is just a standard enzyme immunoassay, followed by a immunoblot test or a Western blot test, or there's now a modified 2-tier test, which is actually 2 EIA tests that are approved by the FDA. And again, I'm going to talk about those more in a minute. So that's a confirmatory lab test. A presumptive lab test would just be the Western blot, an IgG immunoblot or Western blot. And with the blots, they're talking about established criteria. Those are listed down here below in tiny print. That's where you get the number of bands, and I'll talk more about that. I wanted to put this information first to talk about this. This is why we're talking about Lyme today, because this is all really confusing. And so we're going to talk more about all this really confusing stuff. This presumptive lab evidence, again, is used for us to count possible cases. This should not be used by clinicians to diagnose, but we'll talk more about that. Now we're going to go over to this box here to start with. This again is for counting of cases in MDSS, but the definitions are based on whether you're in a high incidence jurisdiction or a low incidence jurisdiction. So high incidence jurisdictions are those areas that have at least 10 cases per 100,000 population for 3 years in a row. Right now, that only includes Connecticut, Delaware, Maine, Maryland, Massachusetts, Minnesota, New Hampshire, New Jersey, New York, Pennsylvania, Rhode Island, Vermont, Virginia, West Virginia, Wisconsin, and DC. It does not include Michigan. When we're determining the incidence for case classification, you go by the state level. You don't break it down to the subdivision level. So I'm just going to click over. For example, in Michigan, we do have some counties that typically have more than 10 cases per 100,000, but for diagnosis for MDSS, we wouldn't take that into consideration. We would just consider Michigan as a whole as being low incidence. So when we look at the case definitions, we would, if someone were likely infected in Michigan, we would look at the low incidence jurisdiction. So I'm going to start at the bottom. For confirmed cases for Michigan, it would be a clinically compatible case. So they either have the erythema migrans or the joint swellings or one of those clinically compatible cases and have the confirmatory lab criteria. So the two-tier test results. For a probable case, you'd have the clinical compatible case and the presumptive lab criteria. So if they just had a positive Western blot. And a suspect case for a low incidence jurisdiction, they have any kind of lab test positive, but you don't have any clinical information available, or they had clinically diagnosed erythema migrans, but there was no lab testing done. So that's how the diagnostic criteria works for our case counting. So it's good to pull those up and kind of work your way through the information that you have. Going through now, I will have some slides that have kind of this look to them, some header slides that have this little image to them. These are slides I actually took directly from the CDC. It's from a series of 4 modules that provide in total over 4 hours of free CME. They're excellent. I put the link here. It's just cdc.gov/Lyme/healthcare. So if you or any healthcare providers, might be interested, this is fantastic CME. I actually went through all of it. And again, it's free credit, but just wanted to share that. And again, let you know where I got some of these slides from. Another excellent resource is from the Association of Public Health Laboratories. I put the web link here, but it gives information about the testing, but also describes how Lyme test results should be reported. So first, to talk about diagnosis and testing for Lyme. This information is from another really good resource, which is from the Clinical Microbiology Reviews and goes over the laboratory diagnosis of Lyme disease. And this is another one that's from really recent 2021. So basically, there's 2 broad categories of testing for Lyme. It's the direct method, which you're actually looking for the bacteria itself. And as I mentioned before, you rarely ever see those. Those are really hard to collect, and it's really hard to culture that organism and to get any positive PCR tests. And then there's indirect testing methods, which you're looking for antibody response. And that's the primary way that we do look for Lyme infection, and there's been a lot of improvement over the years in those tests. So just some other comments on that though, there is a window period after infection with Lyme of several days to a few weeks after infection where you will not find any antibodies. So you'll have basically a false negative. Then you'll have IgM antibodies being produced. And then with time, it does change from IgM to IgG. That does happen pretty quickly, usually within a month, sometimes up to 2 months. When you have the IgM antibodies, those mainly develop against certain antigens on the Lyme bacteria. And those are most consistently to proteins on the surface of the bacteria called protein C or the OpC. And then the VMP. So these proteins here listed, these are some of the bands that you would see positive, the OpC, the VMP, and the FLAB. So when it says you should see 2 out of 3 bands positive, these are the bands or the antigens in the Western blot that are most specific of the IgM. And this is where that nomenclature is coming from. It's from specific proteins in that bacteria that are most likely to create that IgM response. So after a month or 2, you'll lose your IgMs and you'll go to IgG antibodies. And again, you're going to make very specific antibodies to very specific antigens, and it's going to be these 10 different ones here. You don't need to remember them. I have a picture again in a minute. As a note though, if someone with the erythema migrans rash were to go into a healthcare provider, they'd had a tick bite, the healthcare provider knows, gosh, they probably are in the window period. If I do testing, it'll be negative. They're not really supposed to test. They're just supposed to treat with antibiotics then. If they're to test them for Lyme, say 2 months later, it's very likely they could test negative. So if someone was given antibiotics during that window period, so early in the infection, up to half of patients will not ever develop antibodies. So again, just to know that if someone's treated early and they test negative later, it does not mean they did not have Lyme. So this gives those lists of those bands for the Western blot. So for IgM, to be considered positive, you should have 2 of the 3 following bands. And for the IgG, you should have 5 of the following 10. And I'm going to show some images of it in a minute. But that's what we talk about with bands. There are false positives with these bands. There are some of these bands that'll often, like 40% of people might test positive for one, and there's other infections that can cause positivity. So that's why saying that fewer bands being positive could be counted as a positive. There's some that argue that even a few bands, like 3 out of 10 should be considered positive. Well, by doing that, you make it much less specific, and you can actually be causing people to have false positives. So the recommendation is that you use a 2-step testing method and only use FDA cleared tests for Lyme disease. In the first tier of the testing, in the traditional 2-tier testing, you start with an enzyme immunoassay or an EIA. Less commonly, there was an immunofluorescent antibody assay. But basically, this is just a general antibody test for Lyme. It's either positive or negative. I'm going to talk a little bit more about how these tests work in a minute. But if it's negative, then you're done. If it's positive, then you go on to the Western blot test or the immunoblot test. So it's typically then tested for both IgM and IgG antibodies in the Western blot. If it's been more than 1 month since the symptom onset, you need to have IgG positive to be considered positive. If it's only IgM, it typically represents a false positive result, or it could be a previous infection, and it's just the way that the testing is showing up. So that's just something else to take into consideration. So just to describe how these tests work a little bit more, those first tier tests, or those enzyme immunoassays, typically take like the whole Lyme organism or numerous different antigens from the Lyme organism to just see, does this person have antibodies to Lyme or not? So it's really sensitive, but it's not very specific. There can be other things that cross-react and cause a false positive. So we basically are screening, is there any chance this person's been infected by Lyme? The second tier test, or those immunoblot tests, are more specific. So they're looking for antibodies to much more specific antigens found in the Lyme organism. So this is a much more specific test, but it's less sensitive. By having the two tests together, you have much less risk of having false positives. If you do just one of the tests, if you just do the EIA, you're obviously going to have a lot of false positives. And if you do just the Western blot, you could miss some, or you could, have false tests that way too. There are some newer EIA tests, so some of those first tier tests that are FDA approved to be used like a second tier test. They've actually been made using specific isolated antigens from the Lyme pathogen. So these are as specific as those Western blots. So if the FDA has approved them to be used as a second tier test, they can be. And so using 2 EIA tests in a row is called a modified 2-step serology protocol. So this just shows the conventional 2-tiered protocol. So you start with an EIA test. If it's negative, you either look for another diagnosis, or if they're just really early on in their infection, then you'd retest them again, in 2 to 4 weeks. If it's positive or equivocal, if they've been sick for over a month, you would look for IgG immunoblot. If they are really recently ill, then you would look for both IgM and IgG. So this is what we're talking about with the Western blot. On the left side of these are the controls. So these are the 3 bands that you would be looking for. This is an image of an example of a patient sample. So as you can see, they have 1, they have 2, they have 3 bands here. They have 1 really faint, 2, 3, 4, 5, 6, maybe 7. So that's how those bands work, is that, there's specific ones that you need to match up with. The IgM, again, you should really only be considering as part of the diagnosis if it's within the first month of symptoms. This is kind of busy, but this is just a diagnostic flow sheet for someone who has erythema migrans, someone who has symptoms of neurologic Lyme, and someone with symptoms of Lyme arthritis. So it is helpful. It's not so much for us in terms of MDSS, but if you have a provider who has questions, or you have questions, it really does help with making decisions. For example, with erythema migrans, if you have really high suspicion, testing is not necessary. You should just treat. So the modified 2-step protocol, again, you would start with the EIA. If it's positive, you would do another EIA test that's approved by the FDA as a second test. So one question that our providers really should ask is, should they really be testing people for Lyme disease? You know, looking at the pretest probability and you know, what's going on with the patient. So again, in this, in this early phase, there is that window period. So if someone's showing up with the erythema migrans rash and, you know, their chance of exposure just happened, they really shouldn't bother with testing. They should just treat them. This is pretty tiny, but I put the link here. This is a really good handout for yourself or also our healthcare providers, but it really walks through, you know, should I test this person? So, you know, has the person been in an area where Lyme disease is common? Was the person likely exposed to ticks? Does the person have any symptoms of Lyme disease? And then going through, you know, what's the pretest probability, you know, kind of deciding, should I test them or not? And then going through the different tests and then the test results. So basically, if you were in Florida, if you live in Florida and you have generalized fatigue, you know, the chance that a positive Lyme test is positive really means you have Lyme disease would be extremely low. If you live along the lake shore of Michigan and we're out hiking and come in with an erythema migrans rash, and then a month later, you know, you start having joint swelling, the pretest probability is high. And so you could trust the positive test results. That's just kind of the thought process behind that. So I'm going to stop now. Again, from this point forward, I have numerous slides. I think I have 66 slides total, and I'm on slide 23. But I have a lot of slides going over like epidemiology of Lyme in Michigan, how you would manage tick bites. You know, if people need post-exposure prophylaxis, typically in Michigan they do not, but kind of how to decide that, what the signs and symptoms are clinically, what the treatment recommendations are, some other resources. So again, I will share all these slides so you can run through those and have them as a resource. But at this point, I will stop sharing, and if you guys have any questions, feel free to ask.
Doesn't appear to be we have any questions in the room, Dr. Morris. Thank you for that information. We do appreciate your knowledge and expertise in sharing.
All right.
She's going to share the slides, correct, Dr. Morris?
Yes. So the recording should be made into a video that can be shared if anyone wasn't here, and then I will share the slides with Jody and Annette and Lisa, and then they can make sure and get them out to everybody. And then obviously, if you ever have questions, let me know.
Right. And as always, I always attach the recording to the minutes. So if you read the minutes, you can click on the slide and keep it. So,
oh, yeah.
All right. All right. Well, great. Dr. Morris, thank you again for your time. And we will move on to the next agenda item.
Thanks,
Bethany,
guys. Bye.
Thank you.
Thank you.
Bethany, do you want to go now?
We cut you off. That's okay. You guys were stuck listening to me for like 7.5 minutes.
Okay, here.
George, quick question on the.
Do you want to put your laptop down here?
Yeah.
Yeah, I have it here.
Yeah.
I'm just saying it might just be easier. That way you don't feel like you're.
And for ESP, just make ESP know this DHD employee, because they'll bill insurance. Any cold chase. Yeah. Good point, Curtis. Thank you.
What would you like to know when we're done with that employee?
Yeah, so as of now, they're all coming back to my little desk. So I guess the main thing is I just really want to know when it's done. Like, 'Cause otherwise, we all know that there's been like, 30% turnover, something like that, so. But I can't watch a salesperson with a magnifying glass, so kind of like once I hand it over to you guys, just make their appointments, that shoot me an email if they're done. Titers can get faxed, preferably, please don't email me titers because confidentiality reasons, and also full disclosure, my inbox right now is where things go to die, because I'm just not here that much, so like. If you need to send me a document, please just fax it to me, and then it gets to my mailbox, and I don't want to use it. HR doesn't need the titers, I need the titers. And then next time I have a meeting, it'll change, but that's where we're at.
You're an expert on doing blood draws for people that are in like for a report. Because I have never done one before, but I got a request. And I usually call Claire, she's not here. So-
We'll talk after the meeting.
Okay, say court order. Because I looked at, well, I read the workflow, but it said you had to look under your court, but I didn't see.
Yeah, Mason County Court may not be in there yet,
Okay,
so that's
so.
probably part of that, yeah.
93.
I thought 6 weeks ago.
My goodness. Lisa, why Bethany's, ooh.
Hi. Oh shoot, don't take them away. So cold.
But a couple of the big things that they reviewed with us was, we did get a citation for a space heater,
I'm sure.
not to mention it knocked off all the electrical. It's always been that way. So it was just a reminder that there is policy that says we're not supposed to have space. But
So
just
cold.
something for that.
Even if the 85 for you.
Can we turn the heat up? That's nice. All right, I don't know why this is.
I think we all have them, but be prepared that we all also might get sort of open to a government.
How do I make this bigger? I know it's sharing, but it's not. It doesn't let me get this one up. Oh, there we go. All right. I just can't see it. That's fine. I'll turn it to it. Oh, make it happen. Not my first rodeo.
The all staff meeting at about 2.
I can't move it though. Can't move the slides.
Probably gonna be at Paris.
Come on,
Make
like.
sure as your, supply schedules come out and other things like that, that you take into account what we got at the office on December 2nd.
You think it's a long way away. I know what's coming.
Stop it.
All right, it's really not working. We're just gonna do it. Okay. So I gave this a little mini version of this speech almost 4 years ago. So some of you were here, so I apologize if it's a lot of the same information, but So I'm Bethany. Most of you know me. I have stupid amount of nursing degrees that no one should have because I have an addiction problem. But um, one of them is I actually have a social work degree in sexual health counseling and education. So I work a lot with the LGBTQ plus population and have done a lot of work in trying to incorporate this education to become a standard of care. So as a sexual health program, you guys will see this a lot. And probably a lot more than people are willing to tell you unless you know the right languages to use. So we'll talk about that a little bit. I don't have any conflicts of interest. No one's paying me other than my salary to be here. And some of these things are not always the view of the place that I work for. So just so you know. All right, so basically the objectives are so that you guys get a better understanding of some of the language, some of the care, and some of the evidence-based resources that we have at our fingertips to use. And it starts all with this, which is kind of fun because it ties into the ACEs as well. This is Maslow's hierarchy of needs. You guys all know what this is. And basically it is if you don't get the basic needs met, you can't go up a step in the ladder. So if someone is having a hard time securing food, water, sleep, sex is actually on that very basic need. They have a very hard time going up to the safety level. So we make sex very taboo, but if someone isn't getting sexual health needs met in the multiple different ways that it can be, even the simple things as housing safety and feeling safe in their body is not going to be met as well. So you got to keep that in the back of your mind and start normalizing how we talk about sexual health, etc. Yeah.
I don't think your slides are advancing and you can start with share and reshare the slide and see that makes sense.
You bet. Let's see.
Lisa was too shy to speak up.
Oh, you can always interrupt. It's fine.
Yeah, I don't think I've ever been sharing.
All right, let's try that. See, the problem is when I do that, it's up, but it's not. It doesn't let me click on that screen to it. I mean, if I hit, I can't click on that screen to get it out.
So, leave the meeting, come back in. Yeah. Just click on just that screen.
Is it better? That's unfortunate.
Go back to that because you probably still have your calendar on. Or your camera. No, it's up.
Not. All right, well. What's that? It's frozen.
What to do, Bethany?
It's okay. We're gonna do this. Okay, cool. All right.
And they were saying they couldn't hear us, I don't know if that was.
Can they hear?
Because you've got volume on yours, they can't hear.
Can you hear me now? Yes. Okay, cool.
I'm assuming that's what it was.
Okay. All right, so back to Maslow's. So sex is actually the only thing that's listed twice on Maslow's hierarchy of needs, and yet it's still the thing that we talk about the least. So you'll see it at the very bottom with physiological needs, but also in the love and belonging as well. We say that, now it's not